Session 1, Clinical Updates, Part 2. Moderated by Dr. Ahmed Al-Daheri, Dr. Fatima Al-Marzouki, Dr. Huda Rajab.
For the sake of time, we'll start with the first presentation. Our presenter is Dr. Ashraf Radv, who will be talking about chronic pruritus update, concepts, and practical management. Welcome, Dr. Radv. We'll give him just 1 minute. He's fixing the presentation.
Good morning, everyone. It's a pleasure for me to participate in regional academy. Mic, please. Okay. It's a pleasure to participate in the Regional Academy of Dermatology and Venereology this year. Thanks for the organizers. Over the next 15 minutes, I will be talking about the update on systemic management of chronic pruritus of unknown origin. Itching is a very common symptom in dermatology. Many patients come to our clinic for the sole purpose of relieving their itching. It has a significant impact on quality of life. I don't want to repeat that like in every lecture. Chronic pruritus is a subset of pruritus and is defined by pruritus which persists longer than 6 weeks. The lifetime prevalence is 22%, so 1 out of 5 persons will experience pruritus more than 6 weeks. It's much more common in elderly people with up to 50% prevalence compared to younger generation. In this presentation, I will focus not on pruritus in general, but on chronic pruritus of unknown origin. I will first go through the pathophysiology. There are many recent advances in this field. Then the diagnostic workup to make the diagnosis, and the most important, of course, is the therapeutic options available. The pathophysiology of chronic pruritus is quite complex. It involves the interaction of 3 main systems: the skin, the immune system, and the nervous system. This is a very complicated diagram showing the unmyelinated nerve cells, the sensory nerve endings, and you can find here there are so many receptors on the surface of these sensory nerve endings. These, for example, we have opioid receptors, we have histamines. However, histamine is not very important in chronic pruritus. It's important in acute pruritus, in urticaria, but not in chronic pruritus. We have substance P, we have TSLP, we have the itch cytokines, interleukin 31, and we have interleukin 4 and interleukin 13s. These receptors respond to a variety of mediators and cytokines produced by keratinocytes and the immune cells like T helper 2 cells, mast cells, neutrophils, eosinophils, and macrophages. So you can see here the complexity of chronic pruritus. There is no one target for treatment. There are many targets, and each patient might have a different cytokines working. So these are the 3 systems that are involved: the skin, the immune cells, and the nerve cells. With the feeling of itching, the patient scratch, and scratching will damage the keratinocytes, which release mediators, cytokines, proteases as well. So this will activate the immune cells to produce inflammation, and it will activate the itch sensory neuron, causing neural sensitization. Neural sensitization means that a non-itchy stimulus or a lightly itchy stimulus will be perceived by the patient as very itchy stimulus. Also, sensory neurons produce neuropeptides which activate the immune system. You can see here there is a loop forming here. Then each signal will be transmitted to the contralateral spinothalamic tract, to the thalamus, to the itch receptors, and the patient will feel itching, desire to scratch, and so on. So this is very simple explanation. There is a lot of details inside, but I just want to try to keep it simple for the time being. Any patient with itching more than 6 weeks should be assigned to one of these 3 categories, either dermatologic, non-dermatologic, or unknown. Dermatologic is probably the easiest one. We have psoriasis, we have eczema, we have scabies, prurigo nodularis. Any of these conditions, once the diagnosis is made, the disease is treated, itching will be relieved. There are so many causes of non-dermatologic, underlying systemic conditions, malignancy, psychiatric, and neuropathic, polycythemia vera. We have to have a detailed history, examination, and we have to investigate to exclude any of these conditions. This is a must for the diagnosis of chronic pruritus of unknown origin. If the patient does not have dermatologic conditions, does not have any systemic underlying disease, then the patient will be labeled as chronic pruritus of unknown origin. So this is a disease of exclusion. This is a common problem, especially in elderly people, with up to 44% of cases of chronic pruritus falls into these categories. Challenging, there are many challenges with the treatment, as you all experience in your clinic. There are few principles that you have to be aware of. First, there is no FDA-approved medication for this condition. So any medication I'm going to discuss is off-label. There is no large randomized controlled trials, no head-to-head study to compare one medication versus the others. That's why we cannot say this medication is better than the other. And then, because of the complexity of the pathogenesis, recalcitrant treatment usually require more than one treatment. It might require a combination treatment. So in general, we classify the systemic treatments for this condition into 2 categories: immune modulators and neuromodulators. This is conforming with the pathogenesis in which these 2 systems are involved. And under each one, there are few medications that you can choose from. I'm not going to go through all of them. I'm going to go through those medications which can be used by us as a dermatologist. And they are available in the UAE. Okay, antihistamines. Everybody will write antihistamine to patients with chronic dermatitis. They do not really work well in these cases. As I mentioned, histamine is not the primary mediator for itching in chronic pruritus. However, because it's cheap, it's easy, a 1 or 2 week trial of the medication will not harm. You can combine it with H2 antagonist. We prefer the non-sedating antihistamine, especially in the elderly, because in the elderly, using non-sedating antihistamine for a long time can potentiate dementia in those patients. So you can use it for a short time or as a palliative therapy. Psychiatric medications, many of them are available. They have been used for many years to treat chronic pruritus. I think most dermatologists are not comfortable in prescribing this medication, maybe not familiar with this medication. If you would like to write one of them, then you might need to refer the case to psychiatrist or neurologist. If you are confident in prescribing the medication, just you have to be careful with the side effect that can occur in these patients, especially for the elderly ones. Gamma-aminobutyric acid, gabapentin or pregabalin, Lyrica, we used them commonly to treat post-herpetic neuralgia. They are approved for a variety of conditions, and they are used for neuropathic itching as well. So we start with a small dose of pregabalin, which is more effective and better absorption than the gabalin. So we start with a small dose, 75 milligram per day, and build the dose gradually until you reach a maximum of 300 milligram per day. This is not on-demand treatment. The patient has to maintain regularly on the treatment for at least 8 weeks. And we have to tailor the dose. For example, if a patient have nightly itching only, you can give nightly dose only, not a morning and night dosing. And we have to do gradual withdrawal for this medication. There are few side effects with the patients: somnolence, dizziness, fatigue, sedation, and dependence as well. Conventional immunosuppressants have been used for many years to treat itching, chronic itching, methotrexate, cyclosporin, azathioprine, for example. However, in many cases, we do not prescribe them because of the side effects involved, especially in the elderly patient, but they can be used. Recent development of new medications, biologics and JAK inhibitors, has actually changed the way we look at treatment of chronic pruritus. Here, interleukin-4, interleukin-13, dupilumab, and this can also apply to other tralokinumab and lebrikizumab, but dupilumab is available for many years. That's why you find more research on it. Interleukin-4 and interleukin-13 contribute to itching by inflammation and by increasing neural sensitizations. So by blocking this cytokine, we can reduce the itching. This is a small study on 15 patients done on using dupilumab in chronic pruritus of unknown origin. The mean age 68 years, and the mean itch duration was 2.6. They used the same standard dose as with atopic dermatitis. The itch severity score was 8 out of 10 before treatment, and after 10, 20, 30 months, it drops to 1. So very significant reduction of itching for those patients. These patients were not atopic. JAK inhibitors also has been tried in chronic itching because they block many cytokines involved in chronic pruritus, like interleukin-13, interleukin-31, interleukin-4, and TSLP. This is, again, a small study of 16 patients on baricitinib. They used 2 to 4 milligram, and even 2 milligram proved to be a good option here. The patient continues to use emollients and steroids, and the main follow-up was about 10 months. Each score dropped from 8.5 to 3.5, which again, significant reduction, and usually with a fast onset of action. This is a new medication, not available in the United States, about to be available. It's nemolizumab, approved in the United States and Europe for treatment of atopic dermatitis and prurigo nodularis. It is anti-interleukin-31 inhibitor. So you remember I called the interleukin-31 as the itch cytokine. So blocking the itch cytokine can reduce the itch significantly. This is a small study of 12 patients. 3 of them were chronic pruritus of unknown origin. These patients were very resistant to treatment. They have used many biologic treatment, JAK inhibitors, cyclosporin as well. The itch score went from 9 out of 10 to 0.9, so almost no itching. And the action was very fast. 10 out of 12 patients achieved significant itch reduction in only 24 to 72 hours. So the question is, we have immune modulators like the biologic and JAK inhibitors, and we have the neuromodulator like the pregabalin or Lyrica. So which one would you start with? It's a little bit difficult, but there might be some help with the circulating blood eosinophils. Just if you do the blood workup to the patient and the full blood count, look at the circulating eosinophils. A study from Johns Hopkins Itch Centers found that if there is eosinophilia, 4% or more, this is most likely immune-mediated pruritus, and this patient will benefit from immune modulator, biologics or JAK inhibitors. If there is no eosinophilia, this is most likely neural sensitizations, and this patient is better to start with a neuromodulator like pregabalin. In summary, the pathophysiology of chronic pruritus of unknown origin is quite complex. 3 systems are involved. The diagnosis of chronic pruritus of unknown origin is diagnosis of exclusion. You can only make such a diagnosis after comprehensive investigations. Many medications are available. We are now a little bit away from the conventional systemic therapy, methotrexate, cyclosporin. We have the biologics, we have the JAK inhibitors, we have the pregabalin also to be used. Thank you very much for your attention.
Thank you, Dr. Ashraf. Any questions? Okay, let's go, Doctora. You can ask.
Indeed, a very interesting topic. Thank you, Dr. Ashraf. So whatever we talk here, the biggest challenge to translate into our clinic for the treatment is the approval from the insurance. So whatever you told, have you started this with your patients, and how do you go about it? How do you use, number one? And second question was that the NRS scale, I found at one place you had written 0.9. So normally it's a numeric scale which we ask the patient, and are you even telling them to put as 0.1 and 0.2? Normally it is, we are telling them to put it as a digit from 0 to 10. That's what I know of. So could you just help me understand that? Thank you very much.
0.9, probably those who did the study have the scales not only by just 1 centimeter each one, but even by millimeter, and they are very precise in making the 0.9. But this is in the study. Regarding the approval, I don't think that they are going to get approved because this is not labeled in indications. Some patients are able to get the medication from other countries with cheaper medication, and in such case, we go this way, especially here in UAE. We have many people that can go to India, to Egypt, to buy these medications.
I think we will close this session. Thank you, Dr. Ashraf.
Thank
and
you.
if you have any question for Dr. Ashraf, you can upload it on the app. Now it is my pleasure to invite our second speaker, Dr. INT'L Al-Lafi. She will give her talk about allergic contact dermatitis, most often missed in the clinic. Welcome to the stage, Dr. INT'L.
Assalamu alaikum. It's my pleasure to be here, and thanks for the organizing committee for their kind invitation. I'll be talking about a subject that we are all encountering on a daily basis. So I'll take you in the next few minutes in a simple roadmap about the commonest causes of eyelid dermatitis and the implicated allergens, along with how to deal and how to patch test these patients. And I'll share a few cases from my clinic. So eyelid dermatitis, it's a small area. Usually patients will present with erythema, scaleness, maybe stinging, itching, and plus minus swelling. Patients usually, since this is a very sensitive and delicate area, even with minimal attachment of allergens or substances, they will have this irritation. Alongside, they may have an underlying disease like atopic dermatitis or seborrheic dermatitis or even rosacea. So in a study, retrospective analysis of the North American contact dermatitis group data, they studied 2,332 patients having eyelid dermatitis. And surprisingly, it is showing that the commonest cause is the allergic contact, because we know that contact dermatitis, usually 80% of cases are irritant contact, but in the eyelid presentation, the allergic contact dermatitis is taking half of the cases. What about the causes of the allergic contact dermatitis? I like to categorize them into 5 main causes. The airborne, where patients can have it from volatile substances or from the dust or pollens, and also the protein contact dermatitis, namely the IgE-mediated, especially from food, hair, or latex, the irritants because of the chemicals, harsh materials, or soaps and preservatives and fragrances can cause the irritation. Alongside is the atopic dermatitis and seborrheic dermatitis patients. They are more prone to the allergic eyelid dermatitis. So what are the commonest allergens implicated in the eyelid dermatitis? The commonest causes are the metals, namely top 1 allergen worldwide and globally is nickel sulfate, which is available in the eye makeup, shadows, mascara, and even the curlers and tools that ladies are using for their makeup wear. So also we know that nickel is available in the jewelries, in the fake jewelries, so usually the presentation will give you a clue of that. What about gold? Gold thiosulfate is one of the commonest also allergens tested in the standard series and in the standard patch testing. The gold also is worn widely in our region, so patients may come with allergy underneath their jewelry, so 1 month breakthrough can help you identify the allergy of those patients. Fragrances is introduced in different skincare products to unmask unpleasant scents in the products and of the chemicals. So be aware of the products that mention scented, unscented, or fragrance-free, and have this kind of education for your patients. The other thing is the shellac wax, which is a tackifier usually in the eye makeup. The shellac is produced by the lac beetle secretions, and usually it is available in the mascara, lipstick, and also in the adhesive tooth whitening strips. Preservatives very commonly available in our daily skincare products are the methyl isothiazonolone and the methyl chloroisothiazonolone, the MI and the MCI. Also, these are top allergens tested in the standard series. So usually those available in many shampoos that is available in the groceries. So also you should be aware of that. What about topical antibiotics, especially neomycin and bacitracin? These 2 common antibiotics that is used in the ophthalmic ointments are widely causing allergic contact dermatitis, and I advise you not to use it in especially patients having chronic eyelid dermatitis. We know ladies are using now the artificial nails, the nail gelish, and the nail polish. So those are indirectly implicated in the eyelid dermatitis. So please also keep an eye on that. Ask your patients if she's doing any artificial nails or gelish nails. And also you can look for periangual dermatitis. This is also a clue of a problem related to the nails. Do acrylates or acrylic components, all of them are harmful? They are used in the rigid contact lenses and also in the intraocular lenses. So those kinds of acrylates, the polymerized one, are very safe to be used, and they are not causing allergic contact dermatitis. Even gentle products like baby shampoos, tear-free shampoos, do have surfactants that can cause allergic contact dermatitis, and these should be also kept in mind. Even the eyelid hygiene products also can cause allergic contact dermatitis. So while you are counseling the patient, even if they are telling you that we are using, baby products, they are less allergic, keep it and record those products while you are taking history of your patients. We, as dermatologists, we do prescribe topical steroids very widely for different kinds of problems. And sometimes, surprisingly, topical steroids can add to the problem of the contact dermatitis, and namely the eyelid dermatitis. So steroids, there are a specific screening panel for only steroid, which is available in the extended series. And one of the common screening materials are the budesonide and the toxicortyl pavalate. Toxicortyl pavalate are available in the truth test, where you can screen also your patient. So how to counsel your patient with eyelid dermatitis? Detailed history is very important. Take time asking your patients about the onset of the symptoms and any relation to any products that they are applying, they are using, or the work environment, or any recent pains, any recent airborne materials, or going to garden, having pollens. You have to ask all indirect causes of eyelid dermatitis. Ask about their skincare products, their habits regarding nail polish, artificial nails, using the makeup tools, and also ask about the occupational habits and what do they touch in the working environment. So after that, you can go for the standard true test, which is a very simple tool that can be used in our clinic. You can apply the patches on the back of the patient. There are 3 panels. It consists of 36 allergens. It's the top known allergens worldwide that you can use it for screening. Also, if there is the privilege of extended series in your department, you can ask for further investigation with an extended series. If patient is bringing a certain product that he thinks or she thinks that it causes allergic contact dermatitis, you can use the technique of ROWAT, which is repeated open application test. You can examine the product on 25 square centimeter, especially in the elbow, applying twice daily for 3 to 4 days to elicit the reaction. But don't use this kind of technique for harsh materials or for chemicals, because it may cause serious reaction. So if you identify the allergen, what to do next with the patient? Definitely the mainstay of treatment is avoidance of that allergen. We can sit with the patient, educate him, give him a leaflet regarding the materials, where are they, how to avoid them, and educate the patient how to read the products if they are going to buy from pharmacy or from grocery or from makeup shops. And also educate them about the difference between unscented and fragrance-free materials. You can use topical treatments, topical steroids, topical calcineurin inhibitors, and in severe cases, even systemic steroids. These are some programs that can help your patient identify the safest products that he can use, like the contact allergen management program or contact allergen replacement database. So quickly, I'll go through 3 cases from clinic. 3 cases they present with eye problem. The first case of a 43-year-old lady, she came with 8 months history of bilateral eyelid dermatitis. She cannot recognize what causes the problem. Is it the makeup removers, or the eye drops? We've asked her about the hair dye, nail polish, and I asked her to bring her products. She brought all her makeup and eye makeup removers. So we proceed with the patch test. She showed positivity to methyl isothiazolinone. We check it in the wet wipes that she's using. She showed methyl isothiazolinone was there in the eye makeup removers and the wet wipes, and also the methyl chloroisothiazolinone. So what are these materials? These are preservatives available in the industry, in the paints, in the adhesives, and also in the skin care products and in the cleansers, as well as in the wet wipes and hygiene wipes as in our case. Also, these materials can be also getting in contact with the skin of the patient, especially after house painting or tiling glue. So ask about any recent paint in the work or at house. Okay. The second case is a case of a lady, 56. She was referred from ophthalmology, having a problem in her eyes, where the ophthalmologist prescribed eye drops in the form of prednisolone sodium and asked her to wash her eyes with a baby shampoo. So we proceeded with a patch testing. She showed positivity to the toxicortyl pavalate. And also in the steroids series, again, toxicortyl pavalate was there. What is toxicortyl pavalate? It's one of the anti-inflammatory topical steroids. It represents group A. According to the structural groups of steroids, they are classified into different groups. Class A is one of the commonest screening materials. One of them is the toxicortyl pavalate, and they are cross-reacting with other groups. So my last case is a case of 52-year-old man. He has also bilateral periorbital dermatitis. He's been doctor shopping in different clinics to get rid of his dermatitis. So we proceeded with the patch testing. He showed multiple positivity. Just a few examples of his positivity is the AED, the benzyl salicylate, and also the sorbitan sesqualate. So I tried to look into his products in order to identify these positivity. And the AED, it's a stabilizer that is used in different chemicals and skincare products. It was available in his topical preparations. Also, the sorbitan sesqualate is an emulsifier that was present in the topical steroids that he was using. The other thing, he showed positivity to decyl glucoside, which was available in the sunscreen, and neomycin, it was available in the ophthalmic ointment. So my take-home message, topical treatment can add to the patient's problem, and patch testing is essential for diagnosing eyelid dermatitis. Spend time reading the ingredients of any new medication that your patient is telling you it causes or it adds more to his problem. With this, I came to the end of my talk. Just wanted to invite you for our upcoming conference in Kuwait, KSDC, inshallah, next February on 12th, 13th, 14th, and thank you so much.
Thank you, Dr. Atlal, for this excellent presentation. Unfortunately, we will not be able to take any questions as Dr. Atlal is engaged in another session now. So we'll proceed with our third speaker, all the way from Japan, Dr. Shinichi Imavoko, who will present for us JAK inhibitors in psoriasis from clinical trials to real-world experience. The stage is yours, Doctor.
Thank you. Thank you for the kind introduction. Chairman, and thank you very much for inviting me here. This is my first visit to Dubai, and I very much enjoy the city, the great city. So I'm going to start my talk. And let me talk about Fukuoka, my hometown, briefly. Fukuoka is located in the Kyushu Island. There is 4 major islands in Japan, and the southernmost one is Kyushu. And it's the 5th largest city in Japan, and with 3 million people, residents in the city and its vicinity. And the city has many historic sites, but also Japanese pop culture related sites are popular now. And you know, the character from Demon Slayer, his name is, he was named after this shrine in Fukuoka. And also a popular slam dunk guy, his name was taken from the famous sake produced in Fukuoka. Okay, so let's go to take a look at the JAK-STAT pathway. A JAK-STAT pathway is an intracellular signal transduction system, and 2 or 3 JAK, Janus kinase, are bound to the intracellular portion of cytokine receptors. And when a ligand binds to its receptor, JAK phosphorylate each other, figure number 2, and then eventually phosphorylate the molecule called STAT. And the STAT, phosphorylated STAT makes a dimer, and it directly goes to nucleus and serves as a transcription factor. The structure of JAK inhibitor has a characteristic motif, and it's a SUD kinase domain. So there is 4 JAK Janus kinase, JAK1, 2, 3, and TYK2, and they all have a similar structure. And the reason they are called Janus is because they have a kinase domain that actually catalyzes ATP, and also a pseudokinase domain that it looks like a kinase, but do not have a ATP binding activity. So, the name is taken from the Roman gods that has 2 faces. And JAK-STAT system is used so many cytokines, and has a very simple structure. When we compared it with IL-1 family, including IL-36, TNF-alpha, or IL-17 pathway, it's much simpler. It's just JAK and STAT makes the signals, while the old system like IL-17 requires many intracellular molecules and have complex multiple compounds. So this JAK-STAT system is used by so many cytokines. It's written in many, many cytokines and receptors. And the combination of multiple JAKs and multiple STATs can easily make many different pathways. Here you can find only IL-23 is related to psoriasis pathogenesis. Okay, so when we look at the evolution of immunity in animals, IL-17 and TNF-alpha are ancient cytokines that all the animals have, like oysters have IL-17. So they protect themselves from bacteria using IL-17. So they are more innate cytokines. On the other hand, acquired immunity system is only equipped with, in vertebrate, it's upper than fish. And this advanced immune system may have required variety of cells and cytokines, and JAK-STAT system was suitable for supporting this independent multi-pathway signaling. Okay, then let's think about psoriasis. The main pathophysiology of psoriasis, famously known and simple, it causes too much innate inflammation. And the inflammation here is against the extracellular pathogens like fungi or bacteria. And the system consists of cascade of dendritic cell as an finder or initiator, and the innate lymphoid cell type 3, ILC3, or T T helper 17 is an amplifier that amplifies the signal, and the neutrophils are effectors. So other than leukocytes, local skin, and also other than leukocytes, local skin and mucosa produces cytokines such as IL-17F, IL-17C, IL-36, alpha, beta, gamma. So blocking these cytokines suppress the inflammation and improve psoriasis. And to me, psoriasis looks like a gain-of-function type disease. It's like autoinflammatory disease. Patients with psoriasis can produce more potent inflammation, so they are resistant to infection usually, but too much inflammation causes psoriasis. Suppressing this pathway reduces the inflammatory nature to a normal level. So this is why biologics for psoriasis have little side effect, even with a long period, because it is just reducing the level of cytokines to a normal, average level. Biologics are not immunosuppressive if properly applied. And psoriatic arthritis. You know, some of the patients have arthritis. And the core pathological feature of PSA is enthesitis. Enthesis is the site where tendons are inserted into bone. And usually the bone has rough surface. And enthesis receives mechanical stress. And when the stress makes micro damage in the connective tissue, the innate inflammatory system that I showed before recognize the danger signals and inflame as an enthesitis. Therefore, symptoms of PSA are not specific. You know, it's not specific for psoriatic people. And it is usually classified as PSA with the Casper criteria. Since it's not specific, it's not diagnostic criteria, but we can classify the patient as PSA. And then let's see the JAK inhibitors for psoriasis and PSA. The first JAK inhibitor with a label for PSV was tofacitinib, unexpectedly. And it is labeled for RA, rheumatoid arthritis, and IBD now. And Pfizer finished phase 3 trials, and as shown here, it showed a decent efficacy, but did not get labeled as the benefit-risk profile was judged not good enough by FDA. And I was one of the investigators for this trial, and it worked very fine, very nicely in Japanese patients, but a large number of patients had herpes zoster. It's amazing that 17% of the patients had zoster in 1 year. I've never seen such drugs. So tofa failed the label for psoriasis. Then came many JAK inhibitors, mainly developed for RA first, and followed by various diseases, including atopic dermatitis, as you know, for upadacitinib and baricitinib. And upadacitinib also got labeled for PSA, but not PSV. UPA blocks the ATP binding pocket of directly block the ATP binding pocket of the kinase domain. So the specificity is low. Although it is regarded as JAK1 specific, many research show that JAK2 is also inhibited. So you see neutropenia or anemia. The clinical trial of UPA for PSA showed decent efficacy with dose response. ACR20 is used as standard for clinical trials of PSA, and it shows the similar effect with IL-17 blockers. And the Grapper guidelines for PSA shows JAK inhibitors for all domains except nail psoriasis. My personal impression of UPA for PSA is, yes, it's effective, but not so different from IL-17 inhibitors or TNF inhibitors. And UPA is not as good as IL-17 inhibitors for skin symptoms. For psoriasis, TYK2 inhibitor with new mechanism was developed by Bristol Myers Squibb. I found that there's no boost for Bristol Myers Squibb here, and I heard that TYK2 inhibitor is not used in UAE. But the TYK2 is one of the JAK, and this inhibitor binds to, the TYK2 binds to IL-23 receptors. So suppressing the TYK2 specifically blocks the IL-23 signal. It is like an oral, so it serves like an oral ustekinumab. And the way of inhibiting the activity is novel. Deucravacitinib binds to pseudokinase domain of the TYK2.
Professor, you have 2 more minutes, please.
The conformation of a kinase domain so that it blocks the activity of a kinase A. So it is an allosteric inhibitor. Since the pseudokinase domain has more specificity among JAKs, so it's more specific to TYK2 inhibition. And actually, we hardly see the effect on JAK1, 2, 3. So probably this serves as a safer nature. Phase 3 trial of the deucravacitinib showed a decent efficacy with good safety profile. But efficacy comes slowly, like ustekinumab.
Professor, you have 1 more minute, please.
1 minute?
1 minute only remaining.
Oh, really? Okay. So this is labeled in US, Europe, and Japan. And I'm going to show the last slide and patient background. I'm leading a NPO, research NPO, and we had a patients registry. It's a prospective cohort of psoriasis patients, about 3,000 patients. And how is it used? How JAK inhibitors used in Japan? This shows that 1/4 of patients in orals in all systemic interventions, and the TYK2, deucravacitinib, shares 18% of orals. Okay, so this is my summary, and thank you for your attention.
Thank you so much, Professor. We move to our last speaker today, Dr. Arim Al-Buhtami, who will talk about the new gold standard to confirm psoriasis. Welcome, Dr. Arim.
Assalamu alaikum, everybody. I'd like to thank the organizing committee for the kind invitation. And it was Dr. Nisha's idea to present this this topic in the conference. So I'm happy that my lecture is sandwiched between biologics for psoriasis, and our next lecture is going to be about biologics for atopic dermatitis. So psoriasis and eczema is a very, very, very common condition. I think all the dermatologists see it daily in their clinic, and most of the time you can differentiate clinically, right? You don't need to take a biopsy for every patient. So when you need to take a biopsy, then you are not sure, and we really need to be sure because the treatment will differ. So we depend on a lot of criteria. The clinical, it's well-defined in psoriasis, it's ill-defined in eczema. The location is very important. I always try and see where the location is. And so on histology, we also have strict criteria. In psoriasis, you always have, it's dry, so we have the parakeratosis with neutrophils. In eczema, it's more wet, so you have parakeratosis with neutrophils, but with serum. In psoriasis, the hyperplasia is regular. In eczema, it is irregular. And then we have thinning of the suprapapillary plates with dilated vessels, which you see on dermoscopy. And usually in psoriasis, there's no eosinophils, where in eczema, we see eosinophils. So it should be straightforward. And as you can see here histologically, this is a classic case of psoriasis with the thinning of the suprapapillary plate, with the parakeratosis and neutrophils. And on the other side, you see the nice spongiotic vesicles, irregular hyperplasia, but also with parakeratosis. So not every case is straightforward. We have some cases where there's parakeratosis, no neutrophils. And there's cases in eczema where there's parakeratosis and no eosinophils. So these are the cases which are sort of psoriasiform dermatitis. And when the doctor has taken a biopsy of the patient and he gets back the report psoriasiform dermatitis, he's very disappointed, right? So I get about 5 to 10 cases of, is this psoriasis or eczema, on a daily basis. 50%, I can tell you, this is definite psoriasis. About 30 cases are definite eczema. And then there is this gray zone, psoriasiform dermatitis. And I really don't have any clues, okay? There's no neutrophils, there's no eosinophils, and I try and get the clinical photo to sort of guide me, but sometimes it's almost like flipping a coin. Is this psoriasis or eczema? And then we have certain special sites, which are also more complicated. In the scalp, is this psoriasis or seborrheic dermatitis? In the flexure areas, is this inverse psoriasis or tinea? I always like to do a PES in the flexures, because you could be missing a tinea. Acral sites, is this pustular psoriasis or pamphylloxer, this hydrotic eczema? So there is this test developed by Dermagnostics. They say from morphology to molecules, can PCR outperform the expert eye? And we will see if we can answer this question at the end. So before, it didn't really matter. You were giving steroids, patients got better, whether it was psoriasis or eczema. But now we need to be more precise. So this test is based on 2 genes, NOS2 and CCL27, with 2 reference genes to make sure the test has worked. And before, this test was done by PCR, so it was a very long test. You had to have a specialized lab to do it. But they were able to put this test on a disk, and everything is automated and done on this disk. So it is done on the same sample you take, the paraffin block. You take a few more sections and put it in this disk, and everything is automated. And they're able to extract the RNA. And then you get 3 results. If this level of the genes they're looking for is above 55%, this is psoriasis. closed. If it's below 45%, it is psoriasis improbable, so it's not psoriasis. We can exclude psoriasis. And then there's a gray zone in between, if it falls between the 45 and 55%. So here are some of my results I'd like to share with you, and I will show you some cases. So as you can see, most of the time, it is clear-cut. 24% psoriasis improbable. Then if it's between, it becomes undetermined. And these, I call them not psoriasis. It's not psoriasis. And then you see 84%, this is psoriasis, and then 39% not psoriasis. So this is the result you get, sort of black and white. So I would like to share with you some cases. So this is a case, is this psoriasis or eczema? So 31-year-old man, he's known to be atopic dermatitis for 1 year, and then he developed these new lesions. And actually, we're not querying psoriasis at all in this case. Is this tinea or eczema? He's a known eczema. But look at the pathology. We have nice parakeratosis with neutrophils, and it is dry. We have psoriasiform hyperplasia. So what do you think? Is this psoriasis or eczema? Psoriasis, okay. That's what I think as well. So my diagnosis was mounds of parakeratosis with neutrophils consistent with psoriasis. And then I did the test. This patient had a previous biopsy 3 years ago that was called favor eczema. So the doctor called me back and said, you know, you diagnosed this patient as eczema before. Now you're saying it's psoriasis. So I said, okay, let's do the test. And the test was 31%. So it is not psoriasis, it is eczema. So based on the PCR, I had to change my diagnosis and call this eczema. So second case. So this is a 26-year-old female with this diffuse rash on the trunk. And the differential was pityriasis rosea, guttate psoriasis, and PRP, pityriasis rubra pilaris. So here is the biopsy. We see mounds of parakeratosis with neutrophils. There is a lymphoid infiltrate in the dermis, and there is a lot of extravasated red blood cells. So the differential of mounds of parakeratosis with neutrophils and red blood cells would be, my top would be guttate psoriasis because we have neutrophils. But the differential also would include RPR and pityriasis rosea because there is extravasated red blood cells. So clinically, what do you think? Psoriasis? Okay, so I favored also guttate because there is parakeratosis with neutrophils. And I did the test, and it was not psoriasis, 27%. So at least I could exclude psoriasis. And based on the clinical picture, I think this fits more with pityriasis rosea. So this is how this test was able to help me. Another case, this was a single lesion on the breast. 71-year-old female with this infiltrated lesion on the left breast, 1 centimeter in diameter, psoriasis, Paget's, pseudolymphoma. And as you can see, we have parakeratosis, there was neutrophils, regular psoriasiform hyperplasia, but there was eosinophils. So what do you think? Is this psoriasis or is this nummular dermatitis? Nummular dermatitis. Okay, so I called this psoriasiform dermatitis with eosinophils, and I favored psoriasis because we had everything else for psoriasis, and did the test. It was psoriasis, 77%. So this turned out to be psoriasis. Single lesion with eosinophils. So moving on to the scalp, 17-year-old man, is this psoriasis or seborrheic dermatitis? What do you think? Psoriasis. Yes, this is classic psoriasis, okay? parakeratosis with neutrophils diffuse, regular psoriasiform hyperplasia. So this one, I did not do the PCR. I don't need. This is classic psoriasis. So I wanted to show you that you should still have faith in the biopsy. Another case, psoriasis versus seborrheic dermatitis, also on the scalp. What do you think? Psoriasis or seborrheic dermatitis? I'm hearing a lot of mumblings. Okay, the biopsy wasn't very good, really. There is psoriasiform hyperplasia. There's a little bit of parakeratosis at the opening of a hair follicle. So I would go with seborrheic dermatitis. What do you think? Yes, seborrheic dermatitis. So I favored seborrheic dermatitis and did the test, and this was psoriasis, 90%. So you see, the test does help. Okay, acral sites, what do you think? Is this psoriasis or just like in simplex chronicus, prurigo nodularis? We have diffuse parakeratosis with neutrophils, regular psoriasiform hyperplasia. I sometimes have residents with me and I ask them to help me clinically. What do you think? Is this psoriasis or not? Because histologically, it can fit with both. So it could be like in simplex chronicus, just excoriated, or it could be psoriasis. What do you think? You think it's psoriasis? Okay. It was undetermined. So I don't think this is psoriasis. I can't call it psoriasis. Okay, and I think this is my last case, palms and soles, and this is quite a difficult area. So this is a 32-year-old man, psoriasis versus eczema. And here is the pathology. I had nice spongiotic vesicles. I had eosinophils in the dermis. As you can see, there's a nice eosinophil in the bottom right there with spongiotic vesicles. So what do you think? And here there's the eosinophil. Yes. So my diagnosis, this is straightforward. Acute vesicular spongiotic dermatitis with eosinophils consistent with dyshydrotic eczema, Pomphilox. Signed it out, no problem. And then the doctor calls me back and tells me, this is psoriasis. The patient has all the features of psoriasis. He has nails, he has other rashes on the body, he has on his acral sites. So I said, okay, let me do the PCR. I'm almost done. So as you see more of the clinical. So the doctor was convinced this is psoriasis. And he was right. So this was palmoplantar psoriasis. And since this case, I had two other cases, classic, exactly the same, which I called eczema and turned out to be psoriasis. So can PCR outperform the expert eye? I think yes. In certain conditions, yes. Yes. So usually in cases which are not straightforward, I would recommend the PCR, and this is the CPT code I put, 81400, and the insurance has been approving this test. In the pipeline, there's another test that was developed by this company to detect early MF, and I got a few discs and I'm trying them out, and they have been surprisingly good, because I've had cases where everything was negative and it was positive in this test, so confirming early MF. Thank you very much.
Thank you very much, Dr. May. If there is, we can take one question. Dr. Reem. Any question for Dr. Reem? There is one.
Okay. Thank you. Thank you. Yes.
We don't need all the time to say eczema and psoriasis. There are definitely some patients have both at the same time. And we notice this when we treat some atopic dermatitis with dupilumab, the psoriasis pops out And those patients, we need to change their treatment. Usually we give them JAK inhibitor, but there are some patients have both disease at the same time.
Yes, that would be that's complicating the issue even more. Maybe this is why I have cases of psoriasis with eosinophils. I've also had cases where the patient has been treated for eczema, say, and then they develop psoriasis. Thank you.